While he's doing that, let me just go over this one slide here. As I said earlier, and you may not recall this or not, but this is a slide that talks about Medicare cannot commingle 95-97 guidelines. Now, WPS is the Wisconsin Medicare carrier. I've not heard any problems from your carrier out here. As a matter of fact, when you look at your audit tool, which I'll show you in a minute, off your website compared to the ones I gave you with Trailblazer, different. So I would say you have a easier way to score notes than with those people who deal with Trailblazer. But what worries me is that as the one goes, the rest follow. Is that the rest may adopt the Trailblazer audit form going forward, which we'll talk about that in a little bit. But I just wanted to make you aware that here they're saying effective for dates of service April 19th, and after that WPS will change the way it adjudicates the extended level of the HPI when practitioners use 95 versus the 97. So they explain the situation, and they basically say, you know, Medicare will no longer apply the statement from the 97 DG to the documentation when practitioners use 95. Really what they're saying is you can't commingle. Okay. And I brought that up to CMS, and I brought it up to the AMA about 4 years ago, because in the audits, that's exactly what the auditors were doing. They were taking my decision-making bullets from 97 guidelines, which are more detailed, more complex, and applied in the 95 audit guidelines, which are actually, for a multi-system exam process, is not as extensive. You don't have to hit so many bullets. That was the difference between 95 and 97 was really only one thing. For those single specialties like an eye doctor or a surgeon who's only dealing with one body part, they can get up to a level 5 by doing a more extended or comprehensive visit to that one body part. That was the only difference. It was basically an exam. The review system's the same, exams different, decision-making a little bit different on some of the bullets. And so what these auditors were doing is cherry-picking. They would take certain things from the 95 and flip to the 97 and downcode you. You're like, well, how can you be downcoding me? I'm following the 95 guidelines. Then you start questioning them and you find out they were using 97. So this basically is saying they cannot do that. They're breaking the law. Okay? Okay, auditing a note for meaningful content. It's not enough to say yes and no. Pain is a scale of 1 to 10. Anything above level 5 is what? Anything above a level 7 is what? That's decisions we don't know. In other words, if somebody has a pain of 7, is that a level 5 decision or level 5 complexity for that point that you're looking for when you're talking about pain? And anything below 5, is that a level 4? No one's really come up and given me any rules. So that's good, okay? But all I'm trying to say is, in the notes we passed out is a physician friend of mine who went through a very extensive audit with Medicare, and I said, you know, you do such a great job auditing. Do you mind if I take a bunch of your notes and use them in classroom? He said, go for it, Marty. He says, the more I can get people out there to understand what needs to be said in a note, I'm all for it. But I can tell you, when you look at his notes, the 4 I'm giving you, and I got 10 more in your packet, and you look at them very, very carefully, I need to go back to him and tell him he's got to change his ways again. Because what I believed 4 years ago, I'm now seeing a change in how they're auditing making decisions on the level of care today. They're making it more complex for me. Okay, so all I'm doing is raising the bar of warning that we got to do a better job. Okay, and that better job does 2 things in the future. One, we will get meaningful data in the EMR. For paper charts, you won't because you don't have no record, but it's a training ground. I will tell you, any doctor that's not using EMR, that's got a paper chart, if they start doing their documentation right and correctly, first of all, they'll get more reimbursement, which they deserve, and that will actually help pay for their EMR. Secondly, when they go to choose an EMR, they're going to be very stubborn about what they want, because they're going to know what they want because they're doing it right. And they won't deal with what she's dealing with is a system that they're jamming down her throat that's wrong. And they're forcing her to meet their criteria, not hers. See, the EMR should be really based on what the doctor wants, not what some programming guy set up. So I've always said to doctors, get your house in order first. Do everything right in your house so when you plug the EMR in, it's flawless because you'll be the same process. Nothing will change, right? What makes it so hard is the doctor's used to doing one way, and now all of a sudden they're telling him to do it a whole completely different way that he's not used to doing, and that's what's wrong. EMRs should not be designed that way. So the opportunity is to take this time for all you want on paper charts, get your doctors to document better, and for various reasons. If you put the reason you're doing the PET CT in the note, I don't have to come bother you and ask you why you ordered that PET CT. That means your day is going to run more efficient. The double benefit is you get a higher code for that. Because when you put that reason in there, that helps build my complexity level up. And it validates it more. It makes it more true and real. And I can argue more from that standpoint. But if you just say, ordered scan, what scan? Oh, a PET CT. Yeah, you go find the order sheet. Oh, yeah, there's a PET CT. What do you order? That doesn't help me because I have to go dig and find information and attach it to the note and make an argument. And that's not good. That's not good. I'm sorry. That's the reality. But the good news is you keep hammering. If you put this extra stuff in there, I'm not going to bother you too much anymore. And secondly, you're going to get more money. That's a double bonus, right? Double bonus. There's two reasons to get him to try to do it. That's your encouragement. That's one way to get a doctor incentivized. Show him where you can make more money, and he'll usually conform. Especially if he has to do more work, he usually won't. So, exam, comment about positive findings, that's good. It's just saying yes, no is not going to fly. Too many auditors are telling me, if there's something going on in the exam, you've got to make a comment. Come on, give me a break. And I agree with that. And of course, the story and decision-making, discussion with doctor, now in plan, audit backwards, meaning I start at the back and I work to the front. I look at the decision-making, then I make my decision working backwards based on what he's got in the review of system and exam. And remember, 2 out of 3. The highest point's 2 out of 3. So I can have a patient getting chemotherapy, stable, okay? Patient getting chemo, stable, have a level 3 exam, level 5 review, and I still got a level 5. Does that make sense? My history was a level 5, my exam was a 3, my decision was a 5. 2 out of 3. I can have a 5 decision, a 4 review, and a 5 exam. That's still a 5. Or I can have a 4, 3, and a 5. Okay? So that will pull the 3 up to make it a 5. That's right. You don't go down, you go up. When in doubt, you can go up. So if you're missing one point, like typically what I'll miss on the 5 history, I didn't do the 2 history parts. I didn't say past family social history is unchanged. I just said history, social history was unchanged. I missed one point. Well, if I got everything else, benefit of the doubt, you can go up. The auditor should go up. But the auditors today, I'm starting to find, they don't want to do that. They're just really nitpicking. And that's unfortunate. Okay? Okay, introduction of the oncology specialty points and scoring a note. I gave you all a CMS form. Let's see if I can find that. It's back to my table of content. Here it is. Well, I hope you can see that. This is going to be the hardest thing, and I hope we can get through this all, because I'll tell you, this is just mind-boggling. Because I'm going to point out, this is the Trailblazer, CMS Trailblazer form, that I found other carriers copying it and using it. This form, and we talked about this in the last seminar I did, is based on the Marshfield Clinic audit form that was developed by a clinic up in Wisconsin that was part of the initial CPT code creation of the AMA E&M codes. In other words, this multi-specialty clinic called Marshfield Clinic worked with that Dr. Shao to develop the coding. They did what they call time and motion studies. So all the Harvard people went to the Marshfield Clinic back in '92, parked their camp there for a couple of months or 6 months, and from there they did time and motion studies, and they came up with the new coding, which is 95. So Marshfield Clinic kind of went out and said, ooh, we're the gurus for coding E&M. So what they did is they created an internal audit form for their own practice where they put points to it. I defy anybody to go in, which again is in your packet, go read the 1995 guidelines, go read the 1997 guidelines, and you'll see there's nothing in the guidelines that says points. They're except in review of system, HPI, and exam. There are no points in decision making. They were never set up, and they were never set up by the AMA for a very specific reason. Because the E&M coding applies across all specialties. It's generic to all specialties. I don't have E&M for oncology. I don't have E&M for cardiology. I don't have E&M for family practice. It's all the same. So the thinking was, when you get to decision making, it's up to the physician to decide the complexity based upon his specialty, based upon what he says is highly complex. And as you'll see when you look at some of these terms that they use in the guidelines where they talk about highly complex or no. Before we get into this, matter of fact, let me get to this other form. Now I like this form because it's very simple. Okay? And if you go down, if you notice, the form is designed based upon history, second category exam, back is decision making. Got it? Everybody following that? Now, if you look at the history, you can see it goes across 99211, 212, 213, 214, 215. Okay, so what this is saying, if you have a chief complaint history of present illness and you're at a level 1 visit, you don't have to do anything. You don't have to report a review of system. You don't have to report a past family social history. You don't even have to do an exam for level 1. Okay, you just got to make, you don't even have to make a decision. But you go to a level 2, okay, you have to have 1 to 3 elements of the HPI, which is location, quality, severity. Location is usually your diagnosis. That's easy enough to hit. And the rest of them are kind of pain-driven. You know, do I have pain? Yes. When did it happen? Is it continuous? Is it repetitious? Yada, 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 that type of stuff, which we kind of go over later more. I don't want to get into too much in this because this was all talked about in the last seminar we had, okay? But I want to give you a brief overview. Then you go down your review of system, which is pretty easy. You just, here's your body parts, right? Constitution, eye, ears, nose, throat, constitution, or cardiovascular, respiratory. You got one system for level 3. All you got to do, one system. Constitution, I hit it. I don't even have to have a history. So if a patient comes in and says, hi, I'm here, I have a sore throat. It hurts. What's your sore throat? It hurts, right? You've asked me. That's my review of system. What's my exam? I have a sore throat. Stick out your tongue blade down. Yeah, you got a sore throat. What's my decision? You got a sore throat. Simple, right? Okay, so level 4 says, this is really interesting, 2 to 9. Wow, sore throat and a cold. I could be a sore throat and a cold and be at a level 4. 2 to 9, review a system. All I got to do is either get it in the exam, and all I got to do is get 2 body parts. Well, if you come in, typically if a patient comes in with a sore throat, ask any doctor, they're going to go the whole head. They're going to look at your ears, look at your eyes. They're going to check you out, make sure there ain't nothing else going on. Most family practice doctors will tell you that. Pediatricians will do that all the time with kids, right? You may come in with sore throat, but they want to make sure it's not an ear infection, you don't have a cold, or there's some other problem going on. So you're going to hit it right there. So typically a sore throat patient is a level 3. Okay? Because you're only 2 body parts, so I got to hit. 2 to 4. So if I get to an exam, 5 to 7, and I get to 5, 8 or more. Okay? And if you look at the review of systems, I got to hit 10. On review of system, and I get to hit 2 elements of my history. Well, we said a long time ago, and that still applies, doctors should always say, no, past family social history unchanged. That's all you got to do. Because that's one of your repetitive notes. Sorry, but that's one you can easily repeat. Because, what the heck, how many times do you get divorced? How many times do you, run off with the mailman? You can only report so many social family history issues. That's why it's so dumb. So when you get into decision making, here's where it all falls apart, is the decision making. Okay? Now, that's why I work backwards to the front. Because I go back and I look at my presenting problem of the risk. And if you go down there, you can see where it says presenting problem. It says basically, where is it at? I'm sorry, selected management. Drugs causing extensive toxicity. Now, under this medical decision making, this area here, I'm supposed to get the highest point out of these three. So, if I have a stable patient on the presenting problem, which is a 3, but the patient's getting drugs causing extensive toxicity, that makes it a 5. So the 5 of the selected management trumps the presenting problem as a 3. Makes sense, doesn't it? Remember my Hazio thing way back when we talked about the risk, the work, the complexity of the doctor? This takes care of that. So the Godfathers who create the 95 guidelines wanted to leave this alone. They wanted the specialists to create, well, if you want to be technical, if you want a point system, create your own point system. So what the Marshfield Clinic did is they created a point system, which is at Trailblazers, based on primary care doctor. So for example, under the presenting problem, now I'll go back to your Trailblazer form. Because if the patient's disease is progressing, I'm looking at a 5. If the patient's stable, but the patient's getting chemo, I'm looking at a 5. And to me, it doesn't matter whether the patient's getting chemo first day, 5th day, 7th day, 8th days. I don't care, they can get every day in the week. As long as that doctor back there tells me it's medically necessary and appropriate to do a level 5 visit for that patient coming in Monday through Friday to get a chemo, I'm going to bill it. Because he's the guy that's going to have to stand up there and defend it. Not me. He's got to defend it. And usually when you point them to that, they usually say, well, really the 3rd day and the 4th day and 5th day may not be a 5. Well, fine. Quit documenting a level 5. There's your repetitive note, right? It looks and smells like a 5, but it's not a 5. Because it's a robotic note. Hello, let's make a short note. God forbid, can we create a short note? Just call it a short note. And then just set up as a short note. And so it appropriately reflects what you're really doing. That makes sense, that he buys into and his partner buys into, that says, yes, when that patient comes in for the 2nd day chemo or 3rd day or 4th day chemo, we're not going to bill a 5 or a 4. We're going to drop down into 3 category unless what? What happens on the 3rd day? What? Toxicity issues, all kinds of problems, right? Boom, goes right back up again. Because it's unique to that patient, it's unique to that situation. So that's why I like this form, because it's easy, because it don't have points. And let me tell you, when you start looking at this form, you're going to say, I love your form, Marty, because it's a front and back, and it's not 3 pages deep, and I don't have to read all this verbiage in there. Okay? Oh, I found it. Here's, by the way, here, while this is open. Oh, what's it doing? This is the form off of your your Medicare Carriers website. Can you see that? Now you actually have this form listed, okay? And actually, if you go down, there's your HPI. So if you keep this in your hand and the other one, or if you can follow me on this one, I just want to show you one thing here. You can see there's your HPI, your location, quality, duration, blah blah blah. There's your review of system. Comments, here's your history. This is your carrier. This is if you are audited by your carrier, I would expect them to be using this form. And this is why I have it in my file on the date that I downloaded it, because 2 years from now, when they come in, they may be using a different form on the dates of service in 2012. I've had auditors do that. Whoa, dude. You got the wrong form. 2012, we were using this form. It's 2014. What are you doing using this form? Well, that's what we were told you. No. This is the form that was on your website. And by the way, that form is pretty close to my form, so we'll use my form because my form's better. It's more clear. It's more easier to read. Your form's a guide. So, but you can't go start using Trailblazer's form now without giving me due notice, without educating, without telling me. There's supposed to be hearings on this type of stuff. But they're not doing that. So what happens, you get down to the exam, got all the, there they are, yes, no. Basically, that's what this is saying. All you got to do is check the block. So, and then there it says you got to have positive findings. And by the way, the 95 guidelines don't say that either. But it makes sense. To me, it makes sense. Okay. Now we get down to the wonderful decision making. Look what I found. Look at this. Self-limited or minor stable, improved or worsening, 1 point. Established diagnostic problem, stable, improved, 1 point. Established diagnostic problem, worsening, 2 points. New problem, no additional workup, 3 points. New problem, additional workup plan, 4 points. That's right out of the Marshfield Clinic form. If I pulled it up on the screen and showed you that, you'd go, you got to be kidding me. They copyright it. It's a private form. I've had that form thrown out of what I call hearings. I just walk in here and say, Judge, they're using a form that's illegal. What do you mean? Well, I mean, here's the 95 guidelines. He just testified. He says they use the 95 guidelines. If you read the 95 guidelines, there's no points. This guy's using points. He's never educated me. He's using points. I didn't agree to the points. So how can he assign points to something I don't know, have any knowledge about? I don't know anything except he posted on his website. This is where MOASC should be filing a complaint saying you can't use this form. That's what I would like to have MOASC do. File a complaint and say, you have a form on your computer for auditing E&M notes that you should not be using. Throw it out. As a matter of fact, MGMA, the Group Manager Association I was telling you about, they had the Marshfield Clinic form on their website selling it. I forced them to take it off. I said, cease and desist. That form does not exist. It is not following the 95 guidelines. You're selling a form and you're making money off a form that's illegal. They pulled it in 1 week. Okay? That's how you get things done. You make noise. So this is your carrier. So I'm kind of glad that your carrier is using what I call a Mickey Mouse form. It's not what I call a real detailed form. So that's good. I can make a lot of I can make a lot of progress in an audit with them. But now let's go to my wonderful Trailblazer form. Here's the first problem. Look what they did under exam. They basically say, here's a level 2, level 3, level 4, level 5. Under level 3, they say 2 to 7 body system. On level 4, 2 to 7 body. Is that what it says on my form? If I go to 95 guidelines, mine's right. I know it's right because I've audited too many times and I've had auditors and I've won too many cases using that form, so I know mine's right. So this is one thing, they've already made a mistake. That's wrong. Can't do that. They can't use this exam. Then they go up here, and remember that thing that we talked about earlier that said about the HPI 95 versus 97? This is one of the things they've done. They've said here, status of 1 to 2 chronic conditions or 1 to 3 HPI. Status of 1 to 2 chronic conditions or 1 to 3 HPI, which this is interesting. 2 and 3 is the same. Then they go here, they say status of 3 chronic conditions or expand at 4. So what they're saying is if a patient comes in with just breast cancer and is stable, but nothing else is going on, I can't really use my HPI and get up to a 4 or 5 based on this unless I can go in here and find 4 elements of the HPI to get myself credit. Interesting. So if I have a patient coming in that's stable, really has no problems, no pain, how am I going to report? What's your location? Breast cancer. What's your quality? I have no pain. Well, did you have no pain yesterday? Or what was it, 0 to 10? Oh, 0, okay. When did your pain not have? What was the duration, the time frame? I've never had any pain. Okay, well, I'm going to record you've never had any pain. That's my duration. See what I'm doing? This is so stupid. How can I record something that doesn't exist in an HPI? Because this is driven based upon some kind of pain issue going on, unless you get to associated sinus modifying factor. So what we've done is kind of converted this a little bit. Using things like the toxicity or using the staging, diagnosis, we try to kind of tag that into that. But that is a problem. So then you go down to here. Here's your review of systems, which is easy. That one they got right. 2 to 9, and 10 or more. And, of course, your history, they got that right. Then you go down to exam. They got that wrong. Now we go to decision-making. This is the one I really hate. Because they've actually twisted things around. What they did is they created these tables. And they said, number of diagnosis. You get 1 point for each new or established problem of which the diagnosis and or, what is that word? I read off my form. if I can read off of there. A new problem is defined as definitive diagnosis, or for undiagnosed problem, a related group of presenting symptoms and or clinical finding. Each new or established problem for which the diagnosis and or treatment plan is evident with or without diagnosis confirmation. So if the doctor says you have breast cancer, lung cancer, sore throat, I get the same points. Does that seem right? Okay. So what I did is I said, well, you know what's good for the goose is good for the gander. Because I sent letters to the AMA and different people and I complained about, but of course, you know, when you try to complain, it takes 10 years to get them to respond. So what I'm all about is if they can develop a form and use the Marshfield Clinic form for primary care, remember what I said, the 95 guidelines are generic. I, as a specialty group, medical oncology, can create my own forms and create my own points using their format. That's what I've done here. So I'm introducing today the oncology specialty points. So if an auditor walks in and they try to audit you and they have their Marshfield Clinic, you can say, excuse me, that's for primary care. We have our own specialty points form for oncology. That's been sanctioned by MOASC and ASCO and God, or whoever we can get to go along with this. That way I don't have to wait for somebody at the AMA or somebody to come back and respond to me 10 years from now. I want to be proactive. This is one way of being proactive. Okay, so I created my own point system. And I got to thinking about this. I said, well, if a patient comes in and has a cancer, that should be worth at least 2 times more complex than a primary care diagnosis. Now, the doctor might sit there and say, oh my God, Marty, a stage 4 breast cancer is at least 10 times. Well, you know, this is a starting point. You know, and I want to be realistic. As a matter of fact, when I first did this, I actually had 7, 8 points there. And my nurse looked at this and says, you're crazy. They'll never buy that. That's too high. I says, well, I'm looking at this from a complexity. I'm saying to a doctor, do you think a cancer patient is 7 times, 8 times, 5 times more complex than a sore throat? Would you agree with that, doctor? But you couldn't tell me what points. Maybe 2, 4, you know. You'd have to sit with your colleagues and maybe debate that. That's what should happen. That's what MOASC should do. So if they come up with that point system, then we can use that to score our notes and ignore Trailblazer's form, because it will be our audit form. Because when you go through and look at these notes, and the problem is going to be, we're going to try it, but to add these points up is really, it's wild to do this. Because first of all, you get to go down here, and so that's a level 2 sore throat type diagnosis, or in our case would be 2 points. So we get 2 points down at the bottom for diagnosis if the patient just comes in with a breast cancer, lung cancer. That's it. Because you're not going to go up here unless you could come up with 2 differential diagnoses. Breast cancer, sore throat, cold. Breast cancer, neutropenia fever. Breast cancer, you know, some other diagnosis. If you could do that, then you're going to be up into the level 3. Okay? Or if you go level 4, 3 more diagnosis, not 2, they go up a notch. See, what I did is I said, well, that's got to be, if it's 2, then it's got to be 3. If it's 3, it's got, in this case here, I went to 5, because I said, once you get up to there, you got a pretty sick patient. Once you start getting to the 3, what I call additional diagnosis beyond the primary cancer diagnosis. In level 4, I did 4 to 6 ratio. So in the case you're only going to choose 1. So you're either going to have a 1 or a 2 point at the bottom, or you're going to have a 2 or 3 or 4 or 6. You're just going to have 1. That's one group of points for that number of diagnosis, which again, this is why you almost have to have my form, because you're following on the decision making. You're basically looking at the number of diagnosis issue up here, which is up here in section 3. It says medical decision, diagnosis, or treatment option. Does that make sense? See, if you go across mine, which is the AMA, says for the assessment plan, status of presenting problem, treatment initiation, referral, that section, which is sort of this section, minimal 1 diagnosis, limited and treatment options, multiple diagnosis and or treatment option, extensive diagnosis or treatment option. When I see the word extensive, what am I thinking? Cancer. That's what extensive means. It doesn't mean 4. It doesn't mean 3. So they left the words broad. But these people have taken it and tried to tie it into a point system. I can do the same thing. And that's what I've done here. So in this case, if that same patient walks in the door and you look at one of these notes, so one of you, if you looked at an audit from Medicare, you'd give me 1 point for the stage 4 breast cancer. The other ones would give me 6 points. Right? Pretty interesting, huh? Because once you do that, because see, when you get done with all this, you got to add all the points up, and then that helps you decide what your level is based upon 2, 3, 4, 5, because there's more to go. This is just one. So now you go over to management options under Table A. Now this is interesting. They took the management options below, under risk, and pulled it up and put it under the assessment and plan and diagnosis and treatment options. So they've actually done another illegal thing here. They took a risk item in the bottom, because that's what that is, and they pulled it to the top and said, okay, now this is where it really gets fun, because this one is really targeted for oncology. You could see it, because they go down here and say, drug management per problem includes, what is that, name of, huh? Da-da-da-da-da-da. Let's see. Drug management per problem includes same therapy or no change in therapy. If specific therapy is described, record record what is the current therapy is in that the physician reviewed. Dose changes for current medication are not required. However, the record must reflect conscious decision-making to make no dose changes in order to count for coding purpose. So what they're really saying, if the doctor says treat as per orders, that ain't going to fly with that language. They're going to say, well, he really didn't have a conscious, he just said treat as per orders. That's not a conscious decision. That's what they would argue. Okay? So the point is, in that case there, they're basically saying less than 3 new or current medications per problem. Now, does the 3 medications include antiemetics? Medication's a medication, right? So I'm giving 1 chemo drug and I'm giving 3 antiemetics. Am I greater than 3 or am I less than 3? Yeah, I would think greater than 3, but I'll bet you $100 they would say, oh, we don't count antiemetics. That's yeah. Why? It doesn't say that. And it doesn't say it here either, so I got them there too. So my point is I say 2 points and I say 4 points, okay, for these types of decisions. Now, I'm going to go back and talk to my doctors and tell them, you got to be careful when I don't want to see you saying anymore as per order. I have reviewed the chemotherapy orders, and we're not going to make any dose modification changes because the patient evaluation tells me yada, 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 right? Give me something more concrete and specific and patient-specific than just saying, as treated per order, say treated per order, treated per order, because that's what they don't like to see. They don't like to see that robotic notes. Okay. Because see, one of the problems we have, too, is unfortunately, some oncology nurses who got mad at doctors and quit working for the doctors, and then they became auditors. Yeah. They kind of have this little attitude. Okay. So then you can go down. So in this case here, so if somebody's on chemo, okay, you got to give a 1 or 2 points or 2 or 4 points, depend on less than 3 drugs or more than 3 drugs, under the drug management option. If you go down and let's say there is no chemo, but the patient's admitted to the hospital, they say that's worth 1 point. I say that's worth 2 because if we got a patient in the office that's having serious problems, you got to admit to the hospital, they're damn sick. That ain't like a family doctor who's having a little problem wants to admit them to the hospital. Actually, their points most probably should be higher too, if you want to be technical. But they chose 1. I say because we have more complex issues, ours would be a 2. So you could have a patient getting drug management decision, get 1 or 2 points, and all of a sudden you decide to send them to the hospital because there's a problem, right? Then that flips it. But usually what happens when you send them to the hospital, what happens to your E&M code? Gone anyway. You build the admission code. Yeah. Just wanted to bring that point up because people go, oh, well, wait a minute, what about that? Yeah, duh. So anyway, these are other comments in here as far as, and there's other things. These are just suggestions like radiation therapy. If we make a referral to the radiation department, that should be at least 2 points. Or let's say a patient's on concomitant chemo and radiation at the same time, and they come up and you send them back down for radiation evaluation, I would say you could get 2 points, okay, for that. Now, they might say, oh, well, that's really supposed to be just a referral when you initially refer. Well, that's not what you're telling me. That's not what it says. It just says radiation therapy. That's all it says. That's your management option. Your management option today is you evaluate the patient for chemo and radiation. Now you're sending them downstairs for radiation. Well, I'm going to count that as a point. But I got to know that, so help me, doctor. Give me a little note or something in there. This is where I would like some staff to help me get some of these information. So right away, I'm going to have a point under here, which is 1, because you're going to choose one of the 4. Over here, you could have multiple points depending on what's going on. Matter of fact, it's interesting, they don't have blood transfusion in here. But that's one of the, in my form, which it does use as, I put it in there because that's a comparable. In other words, I was trying to think of what's comparable to us. Because most of the things they make suggestions here based on 95 guidelines on my form is really primary care. You can see it in what they're doing. So you could come up with your own little narrative over here on the audit form. Okay, now, that's table A. Got a couple more to go through. Table B. Data to review in order. This one's pretty straightforward. But then again, here's where it falls apart. Because it's basically saying, order and or review medically reasonable and necessary diagnostic imaging studies in radiology CPT codes. So, if I order a PET CT and an MRI and a bone scan, I get a lousy 3 points. If I get a chest x-ray, I get 1 point. If I get a bone scan with a chest x-ray, I get 2 points. They give you no complexity value for ordering radiology, and the same thing for lab. They do the same thing. So if you order one of them specialty labs, or you order one of those a bone marrow procedure lab, very highly complex lab, you get the same lousy point as a CBC, which that makes no sense. So again, I went in there and said 2 to 4 and 1 to 2, so you can see where I'm increasing the level points. Trust me, when you use my points, you're going to be at a level 5 every time when you get down to the bottom. I make no bones about it. I'm not trying to hide anything because I'm calling it what it is. Because really, if you really look at this and you think about it, you say, geez, well, Marty, we really need a level 6, 7, and 8, 9 because your points are not high enough on the acuity to take care of all these highly complex issues. I'm like, yeah, now you're speaking my language. Now you're speaking my language. So when you get to this here, data, you got the same issue. You got to come down and add those points. So you got the points from category A, which is 2 groups of points. Points from B, which is another set of points. It's getting complex, ain't it? Now you get to C. This one here is more subjective because they use minimal, low, moderate, and high, which is in concert with our coding of low, moderate, which is really, actually, it's problem focus, expanded problem focus, detailed, comprehensive. They use the minimal, low, moderate, high. And that's actually, if you go to the 95 guidelines, they do point that out. 97 guidelines, they do put that in there. And they use these issues. And if you notice where it says, let's see, where is it? Look at low. 2 or more self-limited or minor problems, 1 stable chronic illness. That corresponds to my label of risk under presenting problem. You see it? See how they took the worst? So under the presenting problem, this is really the risk table. They're taking the presenting the problem, and they're basically saying the chronic stable illness is a low, okay, issue here. So that's going to be 5, 4, that's your 3. So that matches. It matches with mine. Mine says stable chronic illness, that's 3. That says low, that's a 3. But what they don't do under this moderate and high, the chemotherapy, the drugs causing extensive toxicity is not listed. What's that tell you? Because they knew if they put that in there, that would trump what they did over here with trying to count the drugs under selective management, right? They took that away because that would put you at a high level. So based on what you do here, you have to pick one of these, and you put it down at the bottom as your minimal, low, moderate, high. Nature of the presenting the problem, diagnosis or presenting the orders, and management, option, rest, what we got here? Over-the-counter drugs. That's interesting because over-the-counter drugs, well, over-the-counter drugs, that would be right. Prescription drugs put you to level 4. See it down there? Moderate, go across prescription drug management. So anybody that's coming in that you're doing prescription drug management, you're looking at a 4 level, level 4 right there, every time. Every time. And they agree with that, and I agree with that. So we're in agreement there. So this one's pretty good. But what happens is, what makes it hard is once you get done with this, then you got to go down here, and you got to add up all these points. Under A, B, and C, A, number of diagnosis, B, amount or complexity and risk. So you got 1 point, less than 1 point, or what was that? 1 point minimal, then you got non-minimal, less than 1, then minimal and straightforward. So if you add up the points, you only get 1, basically. You're going to end up with a straightforward. If you got a minimal risk, you're going to be looking at the level 2. You got 2 points, 2 points, you're looking at level 3, 3 points, 3 points of moderate. 4, to get to level 5, you got to have 4 or more diagnoses, right? You got to have more testing being done. So they've tried to quantify this not based on the complexity of the care, it's based on the volume of the complexity of the care. Not even the volume. I don't know what it is because they're saying you've got a list. So my cancer diagnosis would just be a lousy 1 point there. So if I had a high complexity with the cancer, I'll get high points there, but I'm going to get low points on the diagnosis, and I'm going to probably get points on the amount of complexity of data to review. I'm not going to hit my 4. I'm going to be over it at a 3. So anybody getting chemotherapy under their point system is going to put me back at a 4. Okay? Now, if I do my 10-system review, 8-system exam, and the patient's stable, nothing's going on, highest points 2 out of 3, I'm still at a 5. They say, this is the overarching reason, and if we find that this is a 3, even though you got enough points in the review and the exam on a 5, we can drop you down to a 3 on your medical decision making, using the argument that it was not medically necessary and appropriate to buy a higher visit code when it's more appropriate to bill a lower visit code. So if you ever look up the rules, they say that in there. That's their language. So what they're trying to do is take care of the doctors who are building robotic notes, not doing any work, and just plug in their notes with a bunch of garbage that doesn't mean anything. And at the end of the day, that's how they're going to use this kind of a document to downcode us. Now, in a primary care and other specialists, I might agree with them. That might apply, but not in oncology. My problem in oncology is I'm not reporting enough of the high complexity. My notes look like the bad guys' notes of the primary care and other doctors who are padding the notes to try to get a higher level of code. Okay? That's the problem. That's the problem. So, with that in mind, because we kind of talked about this, which we talked about walking backwards on the note, the exam is a clue of complexity, and again, what I would be saying to your doctors, look, if you're really not doing level 5 work, let's back it down to a level 4 visit. Let's do a 5 to 7, okay, a 3 exam. Let's make the note more meaningful along those lines, okay? That's why I want to come up with the category of the visits and then plug in what I think that the exam part and review should be there that then defines my level, okay? That's what this is really saying. Personalized medicine requires personalized diagnostic testing. This is what I talked about earlier. The GenPath people who I work with, my doctors like their lab services. And matter of fact, when you get your little jump drive, they're advertising on there because there's a way for us to get these jump drives, which cost like $700 for these crazy things. But you're taking home a lot of stuff. So they got a little advertising off of it, so that's good. Everybody wins. But I've been working with that company because my docs like them, as a company. And they like the services that they provide, and they don't come in with any bells and whistles. They just straightforward, here's what we do, and they provide a good service. I've been working with them trying to figure out how to get meaningful data from them, as I talked about earlier before that break, to get that in the note to help build my notes so I don't have to add a lot of doctor dictation time, right? In other words, if they can give me a report that the doctor typically would dictate, what the heck, just give me the report and I'll plug it in, and he can make a comment. I concur. Or he can make his comments what his interpretation was or what he's going to do with the information. What's he going to do with it now that we know that that gene profiling expression does affect that you should use drug C versus drug B or something, Okay, so that's where I think we can use these companies maybe to help us. Molecular profiling of cancer patients is becoming standard of disease management. She talks about this a lot in her book. A lot of people are talking about that. That seems to be the way to go. I don't know. I'm not a doctor. I just ask them, well, you tell me. And some go like this, some of them go like that. Some cases it does work. So what does that tell me? Jury's still out. The problem is the public's pushing it. When the public starts pushing it, and by the way, these things aren't cheap. These lab tests are $5,000, $10,000. And the other thing, too, when you order the test, you just order on a piece of paper, and they do 1,000 tests, and then they come back and tell you they're going to bill for 100 tests. So you and I, from an audit compliance standpoint, I have no idea what the hell my doctor's ordering. I'm not sure he knows what he's ordering. It's very complex. And so I'm a little worried about that. Okay. All right, so anyway, this is right from the lab order form from GenPath. Comprehensive hemopathology offering. Peripheral blood test, referential assay test, flow cytometry, 6 opportunities, cytogenetics. See, so the doctor goes down and he checks this block, and that orders a test. But no, it doesn't. There's like 50 CPT codes or 20 CPT codes or 10 CPT codes tied behind each one of these type of tests. So what I'm saying to my doctors, I'm a little concerned because you're checking a block saying to do this test. You don't know on the other end they're doing 40 tests or 30 tests or 20 tests, and then they're coming back and telling you they're only using 10 out of the 20. And if anybody remembers years and years ago when we had the chemistry panels, remember we had the Chem 12, the Chem 16, the Chem 21, and all of a sudden they disappeared and became the lipid profile, and they started getting more specific. Where did that come from? Okay. All of a sudden somebody orders a Chem 21, but he's only using 3 tests out of that Chem 21. But it's easier to do the 21 tests because you're running through the machine, but you're still getting paid for 21. So Medicare was paying $25 or $30, but the doctor was only using 3 values. I see the same problem here coming down the road. So I am a little concerned about what these guys are doing. Okay. But, this stuff is complex. This is not worth 1 point when he orders it or when he interprets it. This has got to be worth more points than that. So that's why I think we got an argument. They have our own specialty points. Okay. How bone marrow lab fish testing, PET CT special creates a level 5. These are level 5 services. That's simple. Okay, and we talked about downloading the points and how much points is there. I don't know. That's what I got to get Mo asking you guys to help me decide. Because if I do it on my own, I'm going to look like I'm doing this for me. If the community does it, then United We Stand, Divided We Fall, the community says it, then it becomes the gold standard. So once MOAS signs off on the points, then it goes up the ladder. We get ASCO to sign off on it. Now we're in good shape. Small Business Association. This is something I told you I've had some problems with auditors. And the last one that I had a problem 3 weeks ago, I don't know if you know this. I mean, years ago when we had a problem with Medicare, we just get on the phone and call somebody at Medicare, and they go fix the problem. They go talk to the medical director, Mary Ann and them. I remember I'd come out and we'd go down, sit down in front of the medical director and bring our issues in front of them, and we'd get some things resolved. Some things we get resolved. It was always a compromise, but it was cordial, and we accomplished. That doesn't exist anymore. So legislatively now, the Small Business Association. Now I don't know where that came from. I'm trying to figure it out. SBA. If you got a problem, you go out and you look for ombudsman for Medicare, and this pops up. So if you want to file a complaint against Medicare, I love it. Or a Medicare Advantage program, somebody was telling they're having a little problem with the Medicare Advantage or Medicaid, you file a complaint with this, legislatively, they got to go research it and reply back in 30 days. So this Medicare auditor who was auditing my notes incorrectly, I filed a complaint against her. By the time we got to the second phone call to her, She was saying, you filed a complaint against me. And I said, and? Are we going to talk about the notes or are we going to talk about the complaint? As soon as I got off the phone, I filed another complaint. I said, she's harassing me. So this is a new resource. I don't know enough about it, but I just want to make you aware that this is a resource sitting out there that I think we need to capitalize on and maybe start using it to our advantage. I am filing a complaint, by the way. As a matter of fact, I've already filed a complaint with them about these audit forms. I'm saying the carriers are using illegal forms, and I'm wanting the Ombudsman, the Small Business Administration, to go to CMS at the top level and file a complaint. So the clock's ticking. They should be getting back to me in less than 15 days on what they're going to tell me. So I'll have some more information as time goes on. Okay, we talked about the modifier 25PL. That way to talk about that. We already know about that. Okay, and I got these things are in that packet, which helps when you write that letter, because that ASCO letter is a great letter because it really talks about the issues. So anybody that reads that when you're appealing that modifier 25 with the office chemo, that it's a slam dunk. You shouldn't have any problem with that. Okay. The only other thing I would just talk about real quick, when I was out here last time, I went to a practice. Mary Ann asked me to go over and talk to them. And they said they're doing a lot of pre-authorizations of tests. Are you guys still all doing that? We don't do that back home anymore. Oh, we tell the radiology part it's their problem. We do not pre-cert any more CTs or anything. We write out an order, and we hand off the script, and basically we call up and set the appointment up. We give them the information, and they go get the pre-cert. I just want you to know that's because it's very simple. At least back east, I'm going to tell you what, there's 15 PET scans in town. One guy says, well, I'm not going to do it. I say, fine, I'll send my business somewhere else. I don't care.
Why isn't it that if the ordering physician has to do the authorization?
That's because it just was a status quo.
They have all the doctor's notes. I don't have access to it.
I know that.
And so I have to get the authorization because I do not.
No, you don't. That's because you all are just playing. You're just accepting business as usual. I'm telling you, you just need to start thinking about how to stop this. This is not your issue. This is the radiology department's issue. I have one company, since I got an EMR, I said, you know what I'm going to do for you? If you want to pay for the interface, you can get into my EMR and you can go find any note you want and get your pre-authorization. They love it. No, they just sign the documents. Come on. What's the difference if I send them a fax, right? If I send a note to them on a fax, there's no difference. I just give them limited liability, give them limited access to my system. It's a read-only. They see the note they're looking for. They see the order they're looking for. They go and print off, and they go off, and they're happy as can be. They love it. And when they don't see the documentation they want, they call up and Lisa, Dr. Taylor is not giving the documentation we need. Lisa beats up on him, and later on he starts putting the documentation in EMR because I'm not bothering him anymore, right? So I'm just saying, this thing I just think you ought to start thinking about this because it sounds to me like this is a big problem out here, that you guys are being forced to do all this work and you're not getting a dime for it, right? You're not getting a dime for doing this. I will be apt to tell you if you have to do this, I would start figuring out how much time it takes. I would put in the physician note. I would increase the level of the note just for that. I would. And I'd make the patient stay there until the damn test was done. Tell them if they don't like it, then they can go talk to their insurance company because they're the ones putting us the hassle factor that they can't get the test, right? And if the patient's there face to face, eyeball to eyeball, guess what? I get to increase my level, right? For time. Besides, it's not Medicare, so I could do, I can get away with it. Because Medicare doesn't require this. This is all these managed care. So I just wanted to make sure that. Marianne wanted me to talk about clinical pathways, NCCN, individualized targeted therapy, first, second line. We talked about that earlier, What regimens work best, what antiemetics, we talked about that. That's what the clinical pathway is all about. What ACOs are going to do, to me, is very simple. First line, second line, put them on hospice. That's maybe coming. But we knew that was possibly coming. Is that really going to happen? I don't know. Our payer and clinical pathway is the way of the future. I think the targeted therapy is where things are headed. I'm just seeing too much information coming out that the insurance companies are really buying into this targeted therapy. The biggest pushback is the daggone targeted labs are so expensive. The prices are coming down? Pardon? Well, the drugs are so expensive. Yeah, but the lab tests are like, the lab tests last year were $15,000. Now because there's so much competition, they dropped to $5,000. Still doing those lab tests, they're pretty expensive. So I think that's what's kind of